Welcome back, everyone. In today's episode, we're going to dive into the topic of assessing a patient. This is an important part of your preparation for the Dental Hygiene Boards, so let's get started. First, when assessing a patient, you need to review their medical and dental histories. Step 1 is to classify the patient using the ASA guidelines, which are listed at the back of your book. We'll go into more detail on what ASA guidelines are later. If you have any questions regarding the patient's medical history, it's crucial to contact their physician before starting any treatment. Recording vital signs is another key aspect of patient assessment. The normal ranges are listed in your book, and it's important to memorize these for the test. Let's go over some basics. Blood pressure is measured by systolic pressure, which occurs when the ventricles contract to send blood into circulation, and diastolic pressure, which happens when the ventricles relax to fill with blood returning from circulation. The cuff should be placed over the brachial artery. The pulse represents the beating of the heart, and the respiratory rate monitors breathing. There are several important questions you need to ask when reviewing with the patient. For instance, is the patient under the care of a physician? Has the patient been hospitalized within the past 5 years? And if so, why? What medications is the patient taking, and for which conditions? Does the patient smoke or use tobacco? Is the patient pregnant? And finally, what is the patient's chief complaint for visiting the dental office? In your textbook, there's an example of a patient history form. This form typically includes fields for the patient's age, sex, height, weight, and vital signs, such as blood pressure, pulse rate, and respiratory rate. You'll also record their medical, dental, and social histories, along with their chief complaint. Now let's move on to dental charting, focusing on the GV Black classifications of caries and restorations. This is crucial to memorize for the test. There are 6 different classes, and here's how they break down. Class I involves pits and fissures on the lingual surfaces of anterior teeth, and on the occlusal, buccal, and lingual surfaces of posterior teeth. Class II includes proximal surfaces of posterior teeth, commonly involving occlusal surfaces. Class III covers proximal surfaces of anterior teeth, not involving the incisal edge. Class IV involves proximal surfaces of anterior teeth and the incisal edge. Class V refers to the cervical third of the facial or lingual surfaces of any tooth, often involving root caries. Class VI involves the incisal edges of anterior teeth or cusp tips of posterior teeth. Let's talk about occlusal relationships. It's best to have photos to reference, but I'll explain them as clearly as I can. Class I, also known as mesognathic, is the normal molar relationship, where the mesiobuccal cusp of the maxillary first molar is positioned in the buccal groove of the mandibular first molar. Class II, or retrognathic, occurs when the buccal groove of the mandibular first permanent molar is distal to the mesiobuccal cusp of the maxillary first permanent molar by at least the width of a premolar. Class III, known as prognathic, happens when the buccal groove of the mandibular first permanent molar is mesial to the mesiobuccal cusp of the maxillary first permanent molar by at least the width of a premolar. Now let's discuss malocclusion. This includes various types, such as an overbite, which is the vertical overlap of the maxillary incisors over the mandibular incisors. Overjet refers to the horizontal distance between the linguals of the maxillary anterior incisors and the facials of the mandibular anterior incisors. An open bite occurs when the teeth are not in occlusion between the maxillary and mandibular arches. A crossbite is when the maxillary teeth are positioned lingual to the mandibular teeth. Midline shift, or deviation, happens when the midline of the maxillary central incisors does not align with the midline of the mandibular central incisors. Edge to edge means the incisal edge of the maxillary anterior teeth meets the incisal edge of the mandibular anterior teeth. End to end refers to the cusp tips of the posterior teeth meeting directly. When dental charting, you'll also be noting missing and extracted teeth, caries, and forcations. For forcations, Class I and II use an empty triangle symbol, while Class III and IV use a filled-in triangle symbol. Make sure to check intraoral photographs and radiographs for bridges, implants, root canal therapy, and restorations. You'll also chart calculus, which is mineralized plaque and can be an irritant to the gingiva. Supragingival calculus gets its nutrients from saliva and is often white, yellow, or gray. It's commonly found near the openings of salivary gland ducts. Subgingival calculus, on the other hand, gets its nutrients from crevicular fluid and inflammatory exudate. It's usually dark brown, dark green, or black. To detect calculus, use explorers like the 11 to 12, and pigtail for posteriors, or the Orban type for anteriors, and the cervical third of posterior teeth. Dry the teeth with compressed air, and check for calculus on radiographs. Now let's talk about staining, one of my favorite topics. The colors of plaque can tell you a lot about a patient's diet and habits. There are two types of staining: extrinsic, or exogenous, and intrinsic, or endogenous. Extrinsic staining is removable, and can be caused by bacteria, food, beverages, and tobacco. You can remove it through instrumentation and polishing. Here are some colors and their causes. Black stain is associated with iron, insoluble ferric sulfide, and gram-positive bacteria, typically found on the cervical third of facials and linguals. Bluish-green stain is linked to inhaling metallic dust, usually from occupational exposure. Brown stain is associated with poor oral hygiene or drinking dark-colored beverages like coffee. Dark brown and black stains are caused by tobacco use. Orange stain, though rare, is caused by chromogenic bacteria and poor oral hygiene, typically on anterior teeth. Yellow, brown, and brown stains can be linked to chlorhexidine or stannous fluoride use. The stain results from the reaction of the tin ion in fluoride. Green stain is linked to poor oral hygiene, chromogenic bacteria, fungi, and gingival hemorrhage. Intrinsic staining, however, is not removable. Possible causes include pulpal necrosis, internal resorption, excessive systemic fluoride, and tetracycline use during tooth development. Now, let's move on to periodontal charting. Probing and bleeding on probing are the first signs of gingivitis. Challenges of probing include keeping the tip parallel to the long axis of the tooth, properly angling interproximally without over or under angling, and encountering obstacles like calculus or overhanging restorations. Class I shows early evidence of bone loss where the instrument can enter the depression leading to the forcation. Class II indicates moderate bone loss where the instrument can enter the forcation, but cannot pass between the roots. Class III shows severe bone loss where the instrument can pass between the roots. Class IV is the same as Class III, but with evidence of recession. Assessing forcations requires using the neighbor's probe and evaluating before recommending oral physiotherapy aids. If you see an N on the charting, it means normal mobility. Class I involves slight horizontal mobility. Class II involves moderate horizontal mobility, greater than 1 mm, without vertical displacement. And Class III involves severe mobility with possible horizontal and vertical movement. Stay tuned for more tips and tricks to ace your dental hygiene boards.